Hello, I am Dr. R.D. Khare, Pediatrician from Mumbai. Today, together we will consider some aspects of congenital heart diseases and how to avoid making a small mistake or making or failure to detect some of the diseases where the manifestations may be subtle. In the first place, often the general examination may offer a clue that we are likely to have a congenital heart disease in the child. First, look at the growth. For example, a child is too short or too tall. It's too short a child, for example, in the Down syndrome, I'm looking at a congenital heart disease. Or if I find a webbing of the neck in a female child, maybe I'm dealing with coarctation. Or in an adult patient, if he or she is very tall with long fingers, I may be dealing with Marfan syndrome. Or often anomalies of fingers may be associated with anomalies of heart. So these are the clues which are available on general examination itself, where we are very careful that we are likely to deal with a congenital heart disease, and examination is likely to be more thorough. Having done that, we come to a newborn period, and in newborn period, in the examination, we should make it a point to palpate the heart or the precordium on the left side as well as on the right side, because in a small child, newborn child, the heart sounds may be heard equally well on the right and left side, and it may not be very difficult to miss a big anomaly like dextrocardia, which we can avoid by palpating right and left side of the heart. Second thing is also diagnosing cyanosis in the newborn. Not easy because the newborns are always plethoric and therefore cyanosis may be missed. So let us make it a rule that we should do a pulse ox of every newborn baby before the baby is discharged from the hospital. We all do a thyroid screening test and perhaps even a hearing test before the baby is discharged. Let us make it a point henceforth that before a newborn is discharged, his pulse ox is done, and any pulse ox at 92 or less than 92 is likely to be associated congenital heart disease. In the part of a neonatal examination, and we often see for congenital dislocation of hip, at the same time we should make it a point that our fingers now go on both the femoral arteries and make sure that the femorals are palpable very well, so that we don't make a coarctation of aorta. Not only in the newborn period, later on also in life, when we see an adult patient, our one hand should go on the radial and the other hand should go on dorsalis pedis to make sure that both are equal in intensity in order not to miss an abnormality of circulation because of aortic abnormalities. Then we come to a little older child. For making a diagnosis of congenital heart disease, we often depend heavily on two things. One is easy symptoms of the child which may suggest a cardiac disease, and presence of murmur. So in a child who does not have symptoms suggestive of heart disease and the murmur may not be very prominent, it's not difficult to miss a heart disease, congenital heart disease. And one such condition is atrial septal defect. Children with atrial septal can remain asymptomatic for a very long time, and the murmur may be very soft and subtle at the pulmonary area. The split of the second sound and the fixed split of the second sound may not be very obvious unless we concentrate and study that, and therefore not difficult to miss an atrial septal defect. So we now learn that we not only concentrate on the pulmonary area, the apical area, but also on the pulmonary aortic area in auscultation in every patient to judge about the second sound is often not given due attention to. Coming to the second sound, we know that there are two elements of second sound. The first one is the louder one, aortic, and the second one is pulmonary. Now here we know that the pulmonary element is louder, but if the pulmonary element becomes pulmonary element is not loud, but if it becomes louder and as loud as A2, this may be an indication of pulmonary hypertension developing, because in a child who has got congenital heart disease, development of pulmonary hypertension is always to be taken care of, and a clinical clue to the development of developing congenital pulmonary hypertension can be a loud second pulmonary sound as loud as aortic, or maybe the mid-diastolic murmur of the mitral area, which is a flow murmur. If that disappears, that may be an indication of evolving pulmonary hypertension. Just as diagnosis of pulmonary hypertension is important and not very easy to make out, sometimes in a small child, diagnosis of cardiac failure may not be easy, because the clinical manifestation on which we depend upon in adults, like jugular venous pressure, are not very obvious and easy to detect in children, and therefore a tachycardia, tachypnea and enlarged liver and basal crepitations should be enough to make a diagnosis of a congenital heart disease. Many times there may be a lot of respiratory signs and symptoms in a child who has congenital heart disease because of cardiac failure. For example, a large VSD, and therefore when you do a physical examination, often the respiratory manifestations and findings are dominant, and it may not be very difficult to miss the murmur that may be there with VSD. Therefore, we go on other methods of suggesting a congestive cardiac failure in a child, just as we saw that pulmonary hypertension is also to be taken care of or suggested. Then we come to another thing, is rhythm disturbances in children. Now, rhythm disturbances are relatively uncommon, and one such thing which we would like to go very briefly into is syncope. We know that neurocardiogenic syncope is not at all uncommon, and to give just a little comment for diagnosing and separating neurocardiogenic syncope from epilepsy, we say that in epilepsy the eyes are always open, while cardiogenic syncope they are closed. And a point to be noted about neurocardiogenic syncope, it does not occur when the patient is exercising or physically very active. If a neurocardiogenic syncope occurs in a child who is running, playing, it is not normal, and such a child definitely requires investigation, especially for prolonged QT syndrome. But let us make it a point that even in a typical neurocardiogenic syncope, maybe an ECG to rule out a prolonged QT may be worth it. Having discussed this, we finally come to diagnosis. Occasionally, a systemic disease like infective endocarditis, when we are trying to investigate, we may make a diagnosis of a subtle congenital cardiac defect which may have been missed. For example, like bicuspid aortic valve, which gives rise to double second aortic sound, which may be not very easy to diagnose. And from the diagnosis of infective endocarditis, we are led to an underlying cardiac anomaly diagnosis. So these are some of the conditions which we keep in mind in order not to make a mistake or miss a diagnosis of a congenital heart disease. Thank you very much.